Hello, everyone. This is the New York City Department of Health and Mental Hygiene's update on COVID-19 for New York City healthcare providers. Thank you for joining today's call. Please note that you have been placed in listen-only mode. If you have any questions during the presentation, please submit them via the Q&A portion of the WebEx. We will address them as time allows. The slides from this webinar, as well as a recording of the event, will be made available on the provider page of our website by tomorrow afternoon. Additionally, we thank you for your participation in a brief poll that will be issued during the last 5 minutes of today's event. And with that, I will hand it over to Dr. Mary Foote, Senior Health Security Specialist for the agency's Bureau of Healthcare System Readiness.
Hi, thanks so much, Allison. And you can all advance next slides. And just wanted to thank you all for joining us today. It's nice to be back here with you all. Just looking at the outline, our usual structure of giving a current situational update, updates on guidance, highlight one of a recent important study, and then we have the pleasure of having Dr. Corinne Thompson here again to go over some of the recent epidemiology in New York City, which is especially relevant now, given our recent upticks, and then we're getting a special topic presentation of long-term sequelae of COVID-19. So just looking at where we are right now, COVID-19 worldwide is really picking up, and we're really at an all-time high in many areas. Particularly heating up is the Eastern Mediterranean region, Europe, and South America, and of course, North America. And looking at cumulatively in the U.S., we have, as you can see, a very significant recent uptick in cases. We are actually really in a very concerning exponential phase throughout the country, really, that far exceeds where we've been both in the spring and in the summer. Fortunately, if you look at the bottom, right now, deaths are starting to increase, but there is a bit of a lag in the exponential growth that we hope will be sustained. But unfortunately, as we see an uptick in cases, we expect a couple-week delay before we see real significant increase in hospitalizations, and then there is a lag of another week or two before we really start to see the impact and increase in deaths. So stay tuned and watch closely.
Thank you, everyone, for joining us. My name is Isabel Pedraza.
Hey, Isabel, they're entering as you speak.
Oh, I'm sorry.
Sorry about that. And so cumulatively, we're 11.8 million cases, and we have unfortunately crossed the threshold over 250,000 deaths in this country. So some of the really relevant updates to highlight in terms of vaccine and therapy: the FDA has now granted an EUA for the use of a new monoclonal antibody therapy, bamlanivimab, in people aged over 12 years at risk of severe COVID. And I want to really note that this is an approval for non-hospitalized patients with mild to moderate disease. This is given in a one-time IV infusion, and this has really shown to be in the data that led to its approval, was really shown most effective at preventing the secondary outcome, which was emergency department visits and hospitalizations. So at this time, there are federal supplies that are being distributed throughout the country, and New York State Department of Health, similar to remdesivir, will be responsible for distributing that to around the state. And I'm sure many of you have heard the very encouraging news about the Moderna and Pfizer vaccine trials that have both reported greater than 90% efficacy in their initial phase 3 trials. And so we now have word that Pfizer will be submitting the paperwork very, very shortly for their emergency use authorization, and Moderna should be very close behind that. So we're expecting, if all goes well, that we could have vaccines starting to be distributed as early as middle December. So this is hopefully great news, and hopefully a light at the end of this very rough year that we've been having. And another, just today we got an update from a WHO panel who has recommended against the use of remdesivir in hospitalized COVID-19 patients, saying that there is no evidence that the drug improves mortality. So I'm sure there will be more to come in terms of the U.S. treatment guidelines to reflect some of the newer data on that. So stay tuned and keep your eye on the NIH treatment guidance. And some guidance updates. The CDC had released, this was a couple weeks ago now, a scientific brief that outlining that masks, in addition to providing source control, meaning protecting others, also protects the wearer from exposures to SARS-CoV-2, and that includes cloth face coverings that are at least 2 layers. And this is, if you have not read this, I highly encourage you to. It's very short, but very succinct, and it will give you some hopefully great talking points when talking to your staff and patients. Another big update to note, the New York State Travel Advisory guidance has been changed. So instead of going with the specific state warnings, it has now broadened its mandate to the entire country, with the exception of states that are contiguous with New York State. And so the new rule is that travelers to New York State can shorten the 14-day quarantine by obtaining 2 tests. The first one has to be within 3 days prior to arriving in New York, and a second test, which would be done on day 4 of quarantine after arriving back to New York. If both of those tests are negative, the traveler may then exit quarantine early. And on the topic of New York State guidance, they have required that all SARS-CoV-2 and influenza test results via the electronic clinical lab reporting system, otherwise known as ECLAIRS, has now changed to results must be reported within 24 hours, and that is a change from the initial guidance to report within 3 hours. So this should give a little bit of relief to those that are struggling to keep up with that reporting requirement. So last but not least, New York City has changed their close contact definition for non-healthcare settings, updated to being close contact being within 6 feet of an infected person for a cumulative total of 10 minutes or more over a 24-hour period. And this was done to align more closely with the CDC guidance of close contact. And pulse oximeters, I just wanted to highlight a couple resources that we have as part of a pulse oximeter distribution program that has been happening to try and get pulse oximeters into the hands of the highest risk patients that are presenting for care with confirmed or suspected COVID-19. And to go along with this, and these resources are now available on the website, we have a provider guidance for how to work with your patients and instruct them on using pulse oximeters as part of their home monitoring regimen. And also we have a new patient handout that is currently available in English, but will soon be available in several other languages. So keep your eye out for that. And really want to highlight, if you are using this mechanism, you can also, Medicare and Medicaid would cover prescription for pulse oximeters if you would like to do it that way, especially for telemedicine encounters. You can do it that way, and patient can pick up at pharmacies. And it's really important that, when you're doing this and planning for this type of home monitoring, you really need to have a clear plan with your patients on how often you want them to check in and how you want them to check in. And also just wanted to highlight in the handouts online, you can get information on how they can enroll in New York City's free 14-day text messaging COVID-19 health monitoring program. And it's a text-based app, so they don't necessarily need a data plan or a smartphone. And that will give daily reminders on checking their oxygen levels and customized instructions on what to do based on the range of oxygen reading they're getting. And so this is just taking a look at the patient handout, what it looks like. And as mentioned, this also just gives a brief explanation to patients on when to seek care, and information on how to enroll in the free text support, and also a log to keep track of their daily readings. And also wanted to highlight our new holiday guidance about be festive and stay safe. And this is available also in multiple languages and can be a great handout for patients and staff. And just wanted to highlight, we, along with the CDC, are really trying to discourage gatherings and traveling, except for gathering with your direct household members or your very closest germ pod members. But this guidance also provides tips on how to gather safely as possible, and also provides some ideas for safe holiday activities. And I also wanted to highlight that Zoom has announced that they are offering free unlimited time sessions on Thanksgiving, so you can do virtual gatherings with your friends and family without time limits and a paid membership, without needing a paid membership. And here's another guidance: traveling during COVID-19, don't do it. The long and the short of it, stole the punchline, but this is another resource for you when talking to your patients and staff. And this is just one of our relevant recent studies to highlight. This is a article that was in the MMWR I think 1 or 2 weeks ago, about transmission of SARS-CoV-2 infections in households in Tennessee and Wisconsin between April and September. So the study design, the objective was to better understand household transmission, including transmission from children. This study was conducted in Nashville, Tennessee, and Marshfield, Wisconsin, and index patients were defined as the first person in a household to have COVID-19 symptoms and positive real-time PCR tests, and who lived with at least one other household member. After recruitment, index patients, there were which ended up being a total of 101, and household members, N of 192, were asked to keep a diary of their symptoms and also obtain daily self-collected nasal swabs or a nasal swab plus saliva samples for 14 days. So the results, out of 192 contacts, 101 had positive COVID-19 tests upon follow-up. So that is a 53% secondary infection rate, which is quite a bit higher than we've seen in some other household contact studies. And notably, in terms of looking at children and transmission, among 14 households in which index patient was aged less than 18 years, the secondary infection rate from the index patient aged less than 12 years was 53%, and the secondary infection rate from index patient aged 12 to 17 years was 38%. So there was certainly transmission observed with younger household members being the primary case. So in total, 75% of secondary infections were identified within 5 days of the index patient's illness onset. And one thing I did want to highlight was that in this study, only 40% of infected household members reported symptoms at the time that SARS-CoV-2 was first detected. And within 7 days of follow-up, 67% had reported symptoms at that point. So more than 30% at 7 days were asymptomatic despite having positive COVID PCR tests. So what are the implications for us as practitioners? So household transmission occurs often and early after onset of illness. We really need to emphasize that persons with COVID-19, confirmed COVID-19 should self-isolate as quickly as possible at either the onset of COVID-like symptoms or at the time of testing as a result of high-risk exposure or at the time of a positive test result, regardless of symptoms. And all household members, including the index case, should wear, this is really important, should wear face coverings in shared spaces in the household. And this is something that has been shown to be very effective in reducing household transmission risk in studies from, particularly from Asia. So something to really emphasize. Just because you're at home does not mean you're safe from transmitting to your loved ones. And sorry about that. And with that, I will turn it over to my esteemed colleague, Dr. Thompson, to give us a very important EPI updates on New York City.
Great. Hi, everybody. Can you hear me? I hope.
Yes, we do.
Okay, great. So good afternoon, everyone. Well, thank you for welcoming me back. My name is Corinne Thompson. I'm one of the epidemiologists here that's responsible for one of many things, including the web page here. So we have updated the web page last week with quite a lot of new information, so I thought it would be good to go over the kind of new structure to orient everyone to it, and then focus on the recent epi of what we know to be happening in the city. So there are three main tabs now here. There used to be a lot more, but we now have the latest, which is information that is kind of happening right now. So when you want to understand what is happening now, we recommend looking here. Trends is information since the start of the outbreak over time. So I understand that people still want to see what happened during wave one, but we have now taken that off of the main page. And then totals is the cumulative information since March as well. So this is inclusive of things like rates by race and ethnicity and by poverty, neighborhood poverty level since the start. And then before I go too much further, just again highlight we have all of our data available on GitHub, which you can download. So if you click on this link, you're taken to a page here that has all of the data that are visualized. You can take a look here. We also have very detailed documentation that have been based on questions coming from the public and from journalists and from others from the last several months. So we do really encourage people to read through all of our documentation as there's quite a lot in there. Also just want to point out that there is also a milestones page here, which has been getting more attention recently. And I'll go to that in a second. So here at the top we have a summary of what's happening recently. So we have information by the last 7 days compared to information for the last 4 weeks, and then whether it's increasing or decreasing. So we have our 4 metrics here: the percent positivity citywide, number of cases, number of hospitalizations, and number of confirmed deaths. The milestones page is here. Slightly confusingly, it's on a different page, so you can see the gray line is that 7-day average, and then the green line is the day-to-day percent positivity. So this is in the news quite a lot recently, so this is where it's hiding. It's this milestone page here. So if you click on this link, or if you click up here, that's where you're going to find. So you can see here that the most recent day is 3.02 for the 7-day average. And this is compared to 2.48 for the last 4 weeks. So you can see it's certainly increasing. All of our metrics are increasing, which hopefully comes as no surprise. So one of the most important things that we are happy to share now is a percent positivity by zip code. So this is a 7-day percent positivity values by zip code. All of the information shown on this page is at a 3-day lag. It was chosen as a balance between urgency and accuracy. As you know, it does take time for data to be reported to us, so we don't report out data until 3 days to give us time to hear about what's been happening. So for the 7-day percent positivity, you can hover over each individual zip code, and you can see, sorry, it might be a little small on your screen, but you can see quite a lot of information by zip code. So we have the zip code 10306, the number, we have the name, the percent positivity here is 5.93%, the people tested, and then the people, the actual test rate for that zip code, and the number of people positive. And then you also have the date range in the bottom. And actually, I just updated this, so the data are still filling out because it's updated every day at 1 p.m. and I just updated it. So I think, let's give it a second. All of the graphs yeah, you can see here. So it's updated just now, and you can see, yeah, okay, so it's quite different. So you can see Breezy Point is very high. We're at 9.62% in Breezy Point. And then all that information is also available on a table. So you can, again, sort by the column names. If you click on the column names, you can sort. So you can see here, this is sorted by that 7-day percent positivity value, seeing Breezy Point, Ozone Park, and Tottenville in the top 3. You can also sort by the actual number of new people positive if you're interested. You can search for a particular zip code if that is what you'd like to do, or you can search for by name as well. So just some nice features there for you. And then we also have information by borough. So there's 177 zip codes that we report out on. So it's a little bit difficult to visualize all that information over time. So what we decided to do was to look at it over time by borough. So at the top here is zip codes in the Bronx. So each of the gray lines is an individual zip code. The green line is the Bronx 7-day percent positivity over time, and then the blue line is the citywide percent positivity over time. And the idea here is that you see outliers or anything that's kind of extreme compared to the rest. So when you look at the Bronx, you can see that it's just a generalized increase here, slightly higher than the citywide average among all of our zip codes here. Brooklyn is a little bit of an interesting story. You hopefully know that in late September, early October, there was a clustering happening in South Brooklyn specifically, so you can see that very clearly here. The neighborhoods of interest in South Brooklyn peaked in early October and then started to come down. But again, we're seeing a kind of gradual increase overall. And the story is pretty much the same for the rest. There are kind of several outlines. This is Breezy Point here, and you can also have Ozone Park here in Queens. You can see there's like slight differences here. And then Staten Island is our borough that has the highest overall percent positivity right now, which has been reported on. So that is a lot of information, but we also have just the standard epi curves as well. We have cases, hospitalizations, and deaths. We have citywide. This has been truncated at 90 days, so you can actually see the trends. The individual days by are cases by diagnosis date or by specimen collection date here in light blue, and then the 7-day average is shown in the dark blue. Again, you can see it drops off because it takes us some time to get data to come into us, but we are certainly well or close to now 1,500 cases per day. I should say all of this is PCR-based information. We know that antigen testing is increasing rapidly, and we are working now to try to put antigen information up here. The state does report out antigen testing, so that is one reason why our numbers are different. So stay tuned for hopefully a recent update or an update soon on antigen testing as well. And then just to show you here, we have the breakdown by borough as well. So if you're interested in a particular borough, the actual epi curve over time, you can take a look. Queens has been concerning of late, but frankly, all of the boroughs are slowly starting to increase. We also have hospitalization information also slowly starting to increase. We do know there's a slight delay between cases and hospitalization numbers going up, so we are starting to see some increase here. And then deaths, slow increase, but it's still the lag between the peak of cases and the peak of deaths is even greater. So the overall death counts are still very low, although we do anticipate that these are going to rise as we have more cases. And then just a couple more things of interest here. We have the citywide percent positivity. This is a different way of looking at it. So the milestones page has a fairly truncated time series, but this is a 90-day time series, so you can see over time. Again, you see these blips. These are weekends. We have a lot of clinics and doctors' offices, or smaller offices, are closed on the weekend, so all of our, not all of our, but our weekend values for percent positivity are skewed toward hospitalized cases, which are more likely to be positive, so you can see these spikes on a really regular basis. That actually corresponds most often with Sundays, but you can see here it has steadily grown since about the beginning of November. And then you can also see information by age. So all of the age groups are shown in gray, but the citywide average is shown in blue, with the idea being that you can check out outliers pretty easily. So you can see here 13 to 17s were quite high in September and October and have now gone down, but it looks like a generalized increase for all of our age groups, which is not really a great sign. Virus testing, this is PCR testing again. This is PCR, persons tested by PCR over time. Again, we're trying to add antigen information here as well, but the number of people tested by PCR is shown in this daily is shown in the light blue dashed line, and then the number of that 7-day average is shown in the solid line. We're getting up to, probably will be approaching 50,000 people tested per day by PCR. We also have new information, the total number of people tested by age. So if you scroll over, you can see the kind of relationships of the numbers of people tested by age, and we also have rate by age. One thing to note is that the 0 to 4s are the rate of testing among young children is quite low, but they have a fairly high percent positivity. So from the last update, it was 3.87%. And then I think we have emergency department visits. visits and admits, again, the light blue lines are individual age groups, and then the dark is the citywide average. We are starting to see an increase in admits specifically among 75-year-olds and also the 65 to 74-year-olds. And then before I stop, I just want to also highlight the trends page here, maybe. So a lot of this information is just kind of duplicated from the latest page, just over a longer time period. So you can see when my computer loads it, you can see the epi curve since the very beginning, instead of truncated at a 90-day period. So you can see we are slowly increasing relative to wave 1. Hospitalizations, starting to be able to see an increase there, and then deaths, we're still very, very low, excuse me, citywide on deaths. But that information is also available for all of the boroughs as well, should you be interested. Again, all of this stuff is pretty much the same, just extended over the same time period. But one thing I do want to point your attention to is the test result lag time. So this is the amount of time it takes between specimen collection and report date to eClears, which is the electronic clinical laboratory report system that Mary mentioned. And we have two graphs here. These are both new. The percent of tests that are returned within 2 days, it's about 2/3. Within 1 day, it's about 40%. It's been pretty steady for the last couple of weeks. And then you can also see median lag time over time from the very beginning, with the dark blue line showing the median, and then the light gray showing the interquartile ranges, the 25th to the 75th percentile. So we are looking at this pretty closely. We do expect that this is going to go up, given the volume of testing has increased dramatically in recent days and weeks. So we're keeping a close eye excuse me, on turnaround time. We also have antibody information, but that has been up for a while. There's nothing new there. So I am happy to answer questions on it, but I think that's pretty much it. So I think the number one thing that I would recommend is keeping your eyes on these metrics, and then the thing that I pay most attention to is this graph here, or excuse me, this map here, with percent positivity being a pretty good proxy for incidence, as we know that case rates are biased by healthcare seeking behavior. So Staten Island generally, if I were to summarize in kind of 20 words or less of the top concerns that we have right now, Staten Island definitely has high sustained percent positivity. Parts of Queens around Jamaica have had pretty high percent positivity for a while. Elmhurst and Corona are starting to pop back up, and then most of the Bronx as well has started to light up. So that's a lot. I'm very happy to take questions, and thank you for your attention.
Okay, I guess that comes back to me. So thank you so much, Dr. Thompson. So, I really just wanted to highlight some really translate what all this data means for our general practice in the kind of at the clinic and healthcare facility level. We are looking at what looks like a second resurgence with increasing cases. So this unfortunately is something that we are expecting to potentially get worse with the holidays coming and just pandemic fatigue. So I wanted to highlight some food for thought for you, our healthcare partners. So I would highly recommend that you are reviewing your protocols and policies for telehealth and remote care. Make sure that is robust and implemented as well as it can be. Really think about and ensure that you have a robust pre-appointment and entry screening, and think about whether or not you need to implement more strict visitor restrictions. Really be thinking about, if you don't already have dedicated spaces and times for sick visits and COVID or flu testing, really think about implementing that, special hours in clinic space. Also think about whether or not you can move appropriate staff to telework again wherever feasible, and really reinforce key messages to staff and think about, do we need to do some refresher training on PPE, infection control, what to do when patient reports symptoms or exposure. Make sure that every staff in your facility is familiar with what their expectations are for them to do. And, I just want to say one thing that we are seeing a lot in terms of staff exposures in healthcare facility. A lot of these are happening in break rooms and during out-of-work socializing. So these are things that we really can prevent with strict guidance and diligence, making sure that staff have masks on if they are not actively eating, if they have to have the masks off to be eating or taking a break. Really important to reinforce social distancing and reinforce the importance of avoiding out-of-work socialization without proper precautions. And also, I would encourage you to reinforce to staff about avoiding non-essential travel and safe celebrations and keeping their celebrations to direct household members or their small germ pods. And really, with patients, take any opportunity to encourage COVID testing and, how they can cooperate with test and trace when they're getting tested. And really start laying the groundwork for countering misinformation and increasing patient acceptance for the COVID vaccine when it is out. So really the provider-patient relationship is so important in really laying the groundwork for acceptance and helping us vaccinate as many people as possible when the COVID vaccine comes out. So I just wanted to highlight some of those key messages before we go on. So now we're going to talk about understanding and managing long-term sequelae of COVID-19. So we are seeing increasingly issues with patients after the acute infection stage are continuing to experience long-term symptoms. And we sort of are seeing this in both the post-acute phase, around 3 to 12 weeks from diagnosis, but we are seeing symptoms that are lasting 3 or more months. As we are really starting to follow this more closely and get more data. Symptoms can be subjective, anatomically very diverse, very unpredictable, and very difficult to diagnose. Some of the most common reported long-term symptoms include relapsing and remitting cough. That really seems to be one of the most common things. There's been low-grade fevers. Significant complaint is fatigue, shortness of breath, chest pain, headaches, neurocognitive difficulties, muscle pains, weakness, GI upset, thromboembolism complications, and mental health conditions. So we'll be highlighting some of those as we go through. So what are the risk factors? Older age and the presence of 3 or more chronic medical conditions have been associated with persistent symptoms, but that is not exclusive. We are certainly seeing it with young and healthy individuals as well, under 40. So again, there is really no good way to predict who's going to get it. And we're also seeing it with people that have recovered from both mild or severe COVID-19 disease. So it's really not just a consequence of severe disease. And I think really important to note from an equity standpoint, according to a national survey, fewer Black people compared to white and Latinx people reported returning to usual health 14 to 21 days after COVID-19. Really important to ensure that we are seeing in proper situation. So the first thing we wanted to really is severe question which to be consistent with similar or consistent with male or fatigue syndrome. So some of the management strategies would be focus care on really symptom-based alleviation and consider, if appropriate, referral to rehabilitation specialists, especially rehabilitation clinics or specialists in ME/CFS. And, of course, it's always important to rule out alternate causes when appropriate, considering referral to neurologists to rule out previously undiagnosed chronic disease or autoimmune neurologic disorders when appropriate. Okay, so next slide. And another common one is sleep disorders. And the presentation that you might often see is hypersomnia, insomnia, and misuse of sleep medication. And some of the management strategies for this would be to screen for and treat anxiety, depression, suicidal thoughts, and counsel patients to practice good sleep hygiene. such as, our usual tricks of avoiding caffeine later in the day, no screens before bed, etc. Dyspnea. So this is again one of the most common presentations in addition to the fatigue, and I would add cough to this as well. So the presentation that you might see is the prolonged cough and labored breathing, and some also might describe chest pain or chest burning when they breathe as well. It's very common, and this is multifactorial, could be due to multiple issues, such as related to direct lung disease. And, the exact cause of this is unknown, but COVID-19, as we know, can cause long-standing fibrotic interstitial lung changes, particularly in patients who are older or who have prior pulmonary comorbidities and a history of smoking. And this can also be related to heart disease, and this is, why it's important to really listen to your patients and do a thorough assessment. 20 to 30% of patients hospitalized with COVID-19 will develop cardiac involvement, and those with prior cardiovascular disease may be at greatest risk for longer-term cardiac problems. Even among asymptomatic patients, there has been evidence of ongoing heart disease, including myocarditis and pericarditis. And some management strategies for these issues include evaluate patients' respiratory status at each visit, consider referral to pulmonary rehabilitation or for pulmonary assessment, lung function assessments, instruct patients with access to home pulse oximeter to measure and report their oxygen saturation, and I'll provide some resources at the end for some resources for this. Inform patients that when they are having trouble breathing about warning signs, which would include severe dyspnea or falling oxygen saturation levels. And of course, discuss the patient's access to support around them when they're at home, who can support them if an emergency arises, and to have an emergency plan for that, to make sure that they are able to seek emergency care when necessary. And joint and muscle pain, again, very common presentation would be the muscle and body ache, sometimes including a sharp or burning pain in the lower back, neck, joints, and extremities. And interestingly, this was also a very common presentation that was seen after some other severe coronaviruses, such as MERS or the original SARS 1.0. So it's really unclear exactly what the cause for this is, but it could be a post-immune response issue. And some of the management strategies would be, really more symptomatic treatment initially with analgesics to reduce pain and continued rehabilitation work. And really a huge issue that we are definitely seeing, and this is very multifactorial, is issues or persisting concerns with mental health and well-being. So the presentations could vary widely, but you could see COVID-19 neurological complications manifesting as psychiatric symptoms, including confusion, stroke, encephalopathy, and cognitive impairment. But also there is a very significant concern for psychological sequelae, including depression, anxiety, post-traumatic stress disorder are common and can worsen with pre-existing mental health conditions. And also, this can be compounded with the post-ICU syndrome that has been well described, and PTSD and mental health issues after a prolonged course in the intensive care unit. So some of the management strategies we would recommend: assess psychopathology of COVID-19 survivors. Be very conscientious of this during your visits. You may want to consider, especially the first couple times after seeing somebody, to schedule longer appointment slots so you can do a more thorough assessment. And discuss adaptive coping mechanisms, social support, and mental health services. If you have these services available at your facility, it may be good to create a nice, strong partnership and referral network for this. Your mental health service providers. Really think about screening for suicidal thought and intent, and of course, call 911 if you believe someone is at an immediate risk of hurting themselves or others. And refer patients to trained mental health professionals, including remote 24/7 And just, again, highlight the resource that there's 24/7 emotional support available through NYC Well, through telephone line or other virtual methods. So that can be a resource to patients that you can provide to them when they are caring for themselves at home. So just some other general considerations. We really just want you to understand that physiologic complaints of COVID-19 long haulers are real, not merely psychological. And, if you look at the patient-facing groups and patient support groups, there unfortunately is a huge, description of people presenting to their providers and just being blown off, not being believed, being, the word gaslighted has been thrown around a lot. So, of course, we hopefully can all respond with empathy and give their complaints as best a consideration as we can to help them address and alleviate their symptoms. And of course, it's always important to rule out other more severe or dangerous possible etiologies of symptoms such as flu, asthma exacerbation, pulmonary embolism, et cetera. And continue to be very scrupulous about managing patients' chronic comorbidities to ensure that does not exacerbate the issues. And definitely coordinate care with specialists when appropriate. And you may, if you have the resource, have specific case managers for these types of patients that can really focus on coordinating what could be quite complicated care. And inform COVID-19 patients, that are coming in with symptoms, that prolonged symptoms are common and that it can take weeks or even months for lingering symptoms to dissipate. But we are still in the process of learning a lot as we go along with this, since this is still, a syndrome that is less than a year old. And let patients know that unless they have severe COVID-19 or immune compromise, they are unlikely to be contagious for more than 10 days after symptom onset, even if symptoms are persisting. So that's just another counseling question that comes up quite a bit. And, really think about for you and your clinic staff, how you can support and screen for social determinants of health. Make sure that you are able to provide or lead them to resources for social support, mindfulness, self-care, and, really think about how to address some social determinants of health, disability, housing support, et cetera. And loss of work, unfortunately, we are seeing that there is a substantial minority of patients with post-COVID sequelae that have been unable to return to work either at all or full-time. So encourage patients that have lost their job or remain absent from their work due to COVID-19 sequelae to file for workers' compensation or disability, and as much service as we can provide to support that, the better for our patients to get them through this very difficult time for themselves. And this is just a list of resources, including some at-home exercises and therapy they can do, both for pulmonary rehabilitation and physical rehabilitation. In addition, there are some virtual COVID-19 survivor support organizations that you can refer people to. And we do have a list that is posting, hopefully today, a list of dedicated COVID-19 post-COVID care clinics that are affiliated with several of the hospitals in the city that really provide a sort of one-stop shop for multiple specialties and coordinating care for more complicated patients that are suffering from more complicated post-COVID courses. So just a resource for you if you think that would be of value to your patients. And finally, I wanted to take a moment to give a very fond farewell. Some of you may have heard we are unfortunately losing our beloved Dr. Demetre Daskalaskis, who has been the Deputy Commissioner for the Division of Disease Control since 2017. We are going to lose him, unfortunately, to the CDC. He's moving on to become the Director for the Division of HIV Prevention there in Atlanta. So he has spent many, many years in service in New York City, starting at Bellevue Hospital, where he has spearheaded, even as a resident and med student, he's spearheaded several public health programs focused on community HIV testing and prevention. He's been with the department since 2014, where he served as assistant commissioner first for HIV, and then moved on to the deputy commissioner for the entire division of disease control, overseeing infectious disease-related programs throughout the city. And, you know, I really want to highlight that not only was he our commander-in-chief for the largest measles outbreak of the last 20 years that was centered in New York City last year, he has really been our steadfast captain and incident commander from the very start of our COVID response from January onwards. I just want to tell you guys, if you had any idea how many times he's jumped in front of the bus for the sake of New Yorkers and our healthcare community, you would be amazed. So I really think he deserves a special recognition. So we just wanted to thank you, Dr. Daskalaskis, for all your years of service. We'll really miss you. So thank you, everybody. Here's some references and information on retrieving CME credits, and we can open it up for some questions.
Thanks, Dr. Foote. Can everyone hear me?
Yes, thank you.
Oh, okay. Sorry about that. I think that one of the questions we had, I think Dr. Foote, would be, could you focus on persistent low-grade abdominal pain or any other GI symptoms that we're seeing, and remind us again, of some of the post-COVID GI sequelae?
So that's a great question, and that is something that has not been as well described. We do know that there are often non-specific gastrointestinal complaints, including persistent vague abdominal pain, discomfort, nausea, and certainly there's been persisting diarrhea type symptoms. But that is something that, is still being studied and is not as well described as some of the other ones. But those are some of the ones that we have seen described in the literature.
And I think that kind of underscores your point, right, that we may not be aware of the full constellation of symptoms and to take them seriously. I think we have, so let's actually go back to you, Dr. Foote, for another organ system question. But do we know that there are a lot of patients who experience severe disease who had either evidence of, severe lung injury on imaging or clinical symptoms associated with lung injury? And do we know the prognosis for those patients? There's actually a specific question about lung fibrosis and other permanent sequelae of lung injury.
Yeah, and that's a fantastic question. So we are seeing, the good thing is that we are seeing people recover, a good portion of people that had chest imaging abnormalities. They do often tend to resolve over a few months, and we are seeing, certainly some encouraging data about being able to recover lung function even after ICU or severe disease courses. And it's for those that have had a much slower recovery course. Again, unfortunately, we've been dealing with this for less than a year, so it's really hard to say, how long these sequelae will last in terms of permanence. But we have seen some encouraging data about many people do start to improve, even if it's slowly.
Okay, great. And then I think we have a couple questions. I figure we'd just get all the organ system questions out of the way together. But so we have a question about dysautonomia and POTS. We've also, I know on this webinar, we've talked about post-ICU syndrome. And again, in severe patients, can you just talk a little bit about the neurologic sequelae and what we know about the management?
Actually, Dr. Ray, you might be a great person to speak on post-ICU syndrome. Do you want to start?
Yeah, I think that, well, so I can just say that patients who are in the ICU for COVID are actually, at increased risk for several reasons for developing post-ICU syndrome. And so the reasons for those risks are just, especially at the beginning of COVID, we were using sedation very heavily, and it was necessary for the management. I think there's still quite a lot of sedatives that are required. The ventilator course is often prolonged despite our best efforts. Patients, there was, especially at the beginning of COVID, there was a fear about tracheostomy, which increases requirements for sedation and decreases mobility. And it does seem, and this is not, I can't quote you proof on this, but I think there's a general impression that there is just something about the virus itself. And Dr. Foote talked a little bit about, chronic fatigue and other myalgias post-COVID. And so I think that there might just be something about the nature of this virus and the way the infection occurs that lends itself to weakness and dyspraxia. And I think that there is no magic bullet for the therapy. I think that steroid usage also concomitant with sedatives, which we know steroids do have a benefit, but can increase post-ICU syndrome. I think it's really just long and difficult physical therapy. I don't know at the moment of any particular treatments that have been shown to be, above and beyond or dramatically effective for decreasing post-ICU syndrome. I think anybody who, it's something that it just highlights the point that we brought up earlier, that if somebody has really been hospitalized, if someone's been immobilized even for a short time, I think it is worthwhile to think about physical therapy as soon as possible, and to sort of expect these sort of sequelae. Anything to add, Dr. Foote?
Thanks. I would just add, this is, obviously, as we all know, an incredibly complicated disease. So, the reason for neurologic sequelae are going to vary quite a bit as well. We know there is certainly neurotropism. So, there could be, with encephalopathy, encephalitis, some actual viral damage versus kind of post-immune. There's also post-hypoxia potential issues, as we've seen. Coagulopathy is quite common during the acute course, so there could be some kind of post-stroke manifestations that were not recognized initially. And, of course, the neuropsychiatric, is very enmeshed in some of these patients. So, it's multifactorial, and it really just, this is why it's so important to have an individualized approach with each of these patients, and make sure that we're getting them the best care with specialists as well when appropriate.
Thank you, Dr. Foote. I think I just want to alert everyone to the fact that the poll is up. We really encourage you to answer the poll about the webinar. We do use it directly to develop our content and tailor the frequency and other pieces of this webinar. Allie, I think there was a question, I think on the slide set, it doesn't state when the next webinar will be. Can you just let us know that?
Sure, yes. Our next webinar will be Friday, December 18th from 1 to 2 p.m. We will be updating the provider page, which is linked at the top of your screen there, with registration information for that WebEx. And then we'll also be sending the information out via email the week of December 14th.
Thank you, Allie. And let's get back to the questions. I have kind of a tough one for Dr. Thompson. So, Dr. Thompson, there was just a question in general about, I think, you know, we talked a little bit about the epidemiology of COVID-19 in younger persons. There was just a question about how we can apply that epidemiology when we think about school openings and school closures.
That is a great question, and it is unfortunately above my pay grade. This is a policy decision that I would encourage you to ask our City Hall colleagues. But I mean, just generally, I think as we're seeing a generalized increase in transmission across the board, and I think that you know, especially with that age group percent positivity graph, you'll see it's an increase among all of our age groups. But in terms of how it applies specifically to policies, I'm afraid I'm not the right person to comment on that.
Thank you for that information, and I think there probably isn't a right answer at the moment. I would also reference that we have done we've presented several cases here. We've presented several cases on this webinar or case reports where there is evidence of transmission occurring from places like camps and schools when precautions aren't taken. So I think we're not going to answer at this moment the question of if the EPI can tell us whether to close schools, since that's such a multifactorial decision. But we can say that it is very important that within schools, if they are open, that we do think that there is demonstration that you know, if you don't maintain the core 4 precautions, especially physical distancing, that they can be centers of transmission. And then, apologies, guys, I will turn off my phone. I think, Dr. Foote, there was I'm having trouble finding the specific question but you had a question that you noticed that you wanted to answer.
Yes. So we had a question about anticipating shortages in testing now that we are starting to hit the second wave. So we are, let's just say nationally, you are hearing about issues with testing again, especially for supplies. At this time in New York City, supply-wise, we seem to be okay and steady. In terms of testing capacity, we have lots of capacity. I will tell you that. We are certainly running under capacity, and especially now that we have our response lab, our New York-based pandemic response lab set up, and that has a very large capacity, and that has not been maximized yet. So, you know, we have seen, you know, reports of lines for testing. You know, I think there's a big demand, especially for rapid testing. But I will encourage you to take a look at the New York City Test and Trace listing of sites. They are increasingly setting up not only general testing sites, but specifically rapid testing sites that you can certainly refer patients to if you do not have the capacity or urgent care lines are looking too long. That's a great option. And as of now, we have plenty of capacity in the city for that. And no changes in testing of contacts or cases if they are not exhibiting symptoms. In fact, we are still very, very much encouraging testing of any and all contacts, regardless of symptoms.
Great, and we have one more minute. So, Dr. Foote, we just had a question about the testing and screening recommendations for people who live and work in New York City. Can you just give us a 1-minute overview?
I think we're referring to the health alert, which is recommending more frequent routine testing for particularly higher risk people with more public and frontline facing jobs. And I would say yes, that's always been an aspirational guidance that we would like to, let's say, aspire to. But I think now more than ever, it is important to try and, encourage our frontline public-facing healthcare worker colleagues, in particular, to get more regular testing to ensure that there, is not asymptomatic spread. And actually, especially using the rapid point-of-care antigen tests and other more newer technologies with slightly less sensitivity but good specificity. The more you test in those cases, the better. And I think that's going to be increasingly true as we start to see more home testing and rapid testing options enter the market. So the testing recommendations will continue to evolve, but as of now, that is still our aspirational recommendation, let's say, as laid out in the health alert. Thanks. Oh, and it's 2:00.
All right. Thanks, everyone.
So thank you, everyone. Please be safe over the holidays. We appreciate you taking the time with us this afternoon. And again, utilize that Zoom link or other options to remote celebrate with your loved ones. This is really the home stretch, so let's all do our part as much as we can to stick to the core 4 and lead by example to our patients, friends, and family. So thanks, everyone. Be safe. Have a great holiday.